Hey everybody, my name is John Castro, and I am doing my oral presentation for the project that I created here. I titled it Inpatient HAPI Prevention. So my main focus is trying to find interventions in how to prevent or lower the number of or incidences of HAPI in the current place that I work at. So the way I decided to do this project, or why I chose this, is we do audits for this HAPI incidents in the hospital, and in the past, I don't know, maybe 3 4 months, there have been incline or an increase of HAPI incidences in not just in my unit, but in especially in the ICU um, unit. So I decided what are some ways we can maybe try to decrease the incidence of the HAPI. Um, so like I said, the reason why uh, I decided to do this project again is because of that incidences of HAPI that I had included in my paper. Um, some of the interventions that I had suggested for the project was three things. The first one is trying to promote assistance from the wound care team. And so the way I had described that in my paper is to um, create posters. And so I did have posters posted in the break room in my unit and also in the bathroom, in the staff bathroom, just a kind of a reminder to include the wound care team in assessments for skins. Um, Initially for admissions, if the patient is high risk for skin breakdown, then maybe they're bedridden, or sometimes they come from a nursing home, or they're fell, or they got some pretty thin, paper thin skin, a lot of bruising. Then the poster would remind the nurses or the staff to include the wound care team, maybe add them on a consult to help assess the skin for these patients. And then also part of that poster is, if the patients are busy, to include the wound care team in assessing the skin. If the nurses, bedside nurses, don't have the time to do that, then the wound care team can be called and be able to help with charting or documentation of the skin of these patients that are at risk for HAPI. The second intervention that I did was education. So this one I wasn't really able to get through all the way. So the goal was to have an educational session that will be provided or be done by the wound care team. Actually, um, it was too much going on at that time, and too much different departments. I had to work with uh, the unit educator, the unit manager, the wound care nurses, and for those who work in the hospital, sometimes those things, they're good ideas, but with time restraints and how busy and how quick things work in the hospital, sometimes those things don't come about. So the goal was to have for nurses to sign up for an educational session, which the wound care nurses will lead, and how to stage pressure ulcers, how to prevent them, and how to care for them. But again, it didn't fall through, unfortunately. And so what we ended up doing was just creating an educational email, and how to do that, right? So that was sent out. The issue with that was that we weren't able to confirm which nurses actually read the email. With an actual in-class presentation, there would be a sign-up sheet so that you will know which nurses came by and then actually learned something or actually sat down for the session. So that was one of the weaknesses with that, not following through or not happening in the session. The third intervention that I did was hourly rounding. So in the hospital, there's hourly rounding that occur. So nurses will round on the patients every hour, every couple hours, whatever it may be, what the protocol is for the hospital. So what I did was that I spoke with the unit manager, charge nurses, even some PCTs, to do an alternating hourly rounding. So for my intervention, I put down that nurses will do the odd hours, so 7, 9, 11, 1300, 1500, until the rest of the shift. And then the PCTs will do the even hours. So that'll be your 8, 10, 12, 14, 100, all right? So that the nurses and PCTs won't feel so overwhelmed with having to round every hour per se. There was a little bit of pushback from the PCTs from that, because PCTs, they naturally I would say around more on the patients because I take the vitals, take them to the bathroom, bring them water, whatever. And so PCTs felt like, hey, we're already doing that. Like, how come I have to do this even more? So the way I was able to resolve that, I guess, was that I was able to talk to the nurses and say, hey, when you round on the odd hours for these patients and they need to use a bathroom or need water, then you can supply that for them. You don't have to call the PCTs and say, hey, I rounded on him, but he wants water or he wants to go to the bathroom. Can you take him? Right? It's then become the nurse's job to do that, right? So that the next time or when the even hour comes in and the PCT's round on them, the patient maybe say, hey, I don't need to use the bathroom, I already used it an hour ago. So then that will kind of help ease the load for both PCTs and nurses, I thought. It worked out. Still doing it now. It's not like a hard policy at this point, but it's getting followed along for now. And so far, so good. It's been no complaints. Patients are okay. They have been, taken being taken care of, taken to the bathroom, and things that they need are being provided. But anyways, so that's what my paper is about. Just trying to find ways to prevent HAPIs. Um, and the way to see if these things work, again, is waiting for the audits in the future. The unit manager, the charge nurses, they do the audits for these things. So in the next couple of months, there will be a new audit. I think they do it every 3 months or so. So there will be a new audit and to kind of see if these interventions did actually work or not. Anyways, that's my paper about, that's what my paper is about in HAPI prevention. Thank you.